Up next, we have Dr. Jayanta Das. He'll be talking about lower eyelid reconstruction with respect to the posterior lamella.
Good morning, everyone, and I'm thanks to Rituja to include me for her session. So, posterior lamellar graft, as my all previous speaker mentioned, all in a case-based basis. So, posterior lamella is sometimes very, very important from from visual point of view than anterior lamella, because that is once the posterior lamella is compromised, the cornea is compromised. So, corneal point of view, posterior lamella is one of the very, very crucial. Then to the either we can address into that in tarsus or conjunctiva, two components. Those are indications are actually those already mentioned: tumor, Stephen Johnson, either it may be infection, trauma, or a combined mechanico-psychiatrical ectropion or entropion involving both lead has same results from the same things. So we are going for a reconstruction. Aim of the graft should be one is the structural support and surface reconstruction. As I earlier mentioned, for surface reconstruction is very, very crucial for to protect and for tear film stability. Assessment of capsulopulpibria fascia is another important point for the things if there is a defect, basically in case of the infection and the scar. And assessment of horizontal laxity also to assess, to decide all those points. Posterior lamellar support. There's another crucial point before we address for a grafting or reconstruction, that support we can think, and accordingly we can go for either a hard pellet or that is scleral donor sclera or the other leads tarsal plate to support it. Then only it may, as of course there's a two grafts never. So if we want to go for a mucous membrane graft along with that, then we can mobilize the superior orbicularis muscle in between. This is the basic one of the principle. So, and two types basically is a either tarso-conjunctival or the we can address to the conjunctiva alone. Those are some common defects. And of course, the assessment protocol for all is everything. So it is a ocular, thorough, soft tissue adnexal, even the orbital examination for the blood supply, etc. Examination of the face also for proper control. In some cases of congenital anomalies, we need there is a posterior lamellar reconstruction. Basically, in a case of coloboma, if it is a huge one, it is very, very challenging. Sometimes there may be total absence of loss, total absence of lid, like this. So this is relatively little easy. But what we'll do in such cases? In such scenario, then total reconstruction is very, very crucial. In this particular scenario, generally we will try to do lots of investigation, ultrasound, MRI, then we can decide which part we will touch, and then multiple approaches we can do in such cases. Of course, injury is one of the very, very crucial. In such cases, some are in a very horrible scenario. So what to do? Which lamella will address? It was not properly taken care. So in such scenario, if you want to give some amount to protect the cornea, posterior lamella first. So then that mucous membrane graft, and then sharing of the graft. Somehow that globe can be saved in such scenario. Another very, very interesting case, it was a following Stephen Johnson's. Nothing was there. She was almost a PL positive cases, both the eyes. So in such scenario, generally as per the Western literature, we should go for a amniotic membrane grafting. But I feel only alone amniotic membrane may not help in such scenario. So mucous membrane in a young patient, if the mucosa is healthy, then it is very, very helpful. So I'm showing some results. This was the pre, and this is the immediately with the mucous membrane graft alone, which is of course under GA from all over buccal mucosa, lip, all everywhere. It was done in the same sitting, and then conformer was placed to protect the cornea. Lamellar dissection was done, and BCL was placed without amniotic membrane, and this is the intermediate, and ultimately see 36 fissions from both the eyes. So it is a very, very important in some cases. So posterior lamellar. Another important challenge is with us, as my previous speaker all are dealing with some trauma, tumor. I am telling some those are hidden burning issues in our country. This is another trachoma. Of course, nowadays less. So in such scenario, sometimes we may go for a tarsal fracture. We can treat trichiasis, but sometimes due to the repeated trichiasis and other tarsal fracture may not work. In such scenario, generally mucous membrane graft, or in even very worst cases, we can go for both the eye-bank sclera. I prefer eye-bank sclera and advancement of some muscles, and then we can go for a mucous membrane graft. So tarsal part may be replaced by heart fillet, cartilage, or eye-bank sclera, anyone, and the conjunctival part by mucous membrane grafting and amniotic membrane. If you want to both little technology also in such scenario, definitely mucous membrane graft is better over the amniotic membrane. But if so short period, if that in the disease in not in very advanced scarred cases, then we can go for the amniotic membrane also. Or of course donors conjunctive is one of the best. Technique wise, we may go for a lead sharing technique or grafting, as Dr. Salu already mentioned. Grafting always sharing always better than any graft, because so we can go for evaluation. I want to make Grover sir is waiting for his talk. So detailed evaluation plan, anesthesia, protection of the globe. This is very, very important for during the time of reconstruction. We should protect. Sometimes there may be injury on that one, so that's also very, very important. And that for as that infection may be one of the cause. Sometimes those are already compromised one. So there should not be any postoperative or iatrogenic infection. So those we can take care. Those are the basic physics behind this, how we reconstruct. So we can think as a three-dimensional way. Though there is a two lamina, basically as per our book, anterior lamina and posterior lamina, there is another lamina. It is a mid lamina. Mid lamina, basically the septum plays a very crucial role. So there should be a titration in between for reconstruction in all that physics, because it is a multi-dimensional view. Sometimes in a contracted socket, we can cut short some of our grafting or that one, so that we can utilize if there is a shortening of the one lamina in one lid, shortening in the other lamina. Then we can by a tectonic force, applying tectonic force, we can manage both the lamina in a same sitting with a very simplified way by doing some just a mucous membrane graft and tarsorrhaphy in both the eyes. This is the working hypothesis in 3 axes, X and Y and Z. If that both axes we can able to tackle, then even we can track that things. Okay, only 5 minutes are there. Those are the some points and complications of this is the list. And in such scenario, thank you, sir.
Thank you, Dr. Jayanta, for giving us each and every possible cause of shortening of the posterior lamella and how to